I'm very delighted to be here. Thank you for the invitation, Dika and Thomas and Michael as well. And in the next half hour, I'll go through some aspects of immunomodulation with autologous stem cell transplantation in severe autoimmune diseases. I'm not going to talk about allogeneic transplantation. I'm going to try and cover all the main indications for autologous transplantation. But I'll give a bit of a background anyway. So and my apologies, I would have loved to have come to join you today, but we have EBMT highlights, and I did Riyadh last week, and I've got Delhi next week. So it was a little bit, I have to be back at base to do some work some of the time. But I'd love to come to join you for another meeting in the near future anyway. So let's just start. Let me just see if I can go to the next slide. Here we go. So this is the British press. This is like stem cell miracle. This is the sort of thing you get in the what we call the tabloids. Bone marrow transplant could be used for multiple sclerosis, arthritis, and Crohn's. But what the more respectable British press have homed into reporting the game changer from MS patients. So I hope to give you a bit of background, and we'll go on to a more respectable journal, that is Bone Marrow Transplantation 2018. So this is the activity survey that Jakob Pasveg leads on, and autoimmune diseases have become the fastest growing indication for transplants across EBMT. It's still not very common. It's still a very niche indication, but they're growing and growing, and they're growing largely due to autologous transplant in MS. So I'll just give you a bit of background. So autoimmune diseases, as you know, they're common in the population. Not all are severe. Some are like hypothyroidism that is easy to treat with replacement. Some are chronic intractable health states, but cure remains elusive. It's a sort of final frontier of medicine, and almost all of the patients with severe autoimmune and inflammatory diseases require long-term therapy, and these therapies are expensive. They have side effects in their own right. So the syndrome is really a mixture of the chronic effects of the autoimmune diseases and the treatments. And these patients, they not only have costs, financial costs, but the big personal costs to them when they become progressively disabled, and big costs to society. So there has always been a desire for a one-off intensive means of disease control, and HSCT could be that in some diseases, and that was what was dreamed of quite a long time ago by those very early scientists, Van Beckham, Ikehara, Richard Burt even dreamed of this 3 to 4 decades ago. They did animal models that supported the role of HSCT in or BMT in various urine and other models of autoimmune diseases. And this was supplemented, this is just an example of a very old paper. This is one from Richard Burt, and in 1995. This is an MS model where it was shown that you could treat Lewis rats with EAE with stem cell transplantation. So this work really paved the way. And the other thing that paved the way were these human cases that we have in all of our departments, where we have a patient with leukemia or aplastic anemia who also has an autoimmune disease. We get this dual cure that we see, and we've all seen those cases. But those cases supported the development of HSCT in autoimmune diseases as a specific treatment. So in 1995, the first patients were treated specifically for an autoimmune disease, and that led to some guidelines and the EBMT autoimmune disease database been set up by Alan Tyndall and Alois Gratwal, and also Alberto Marmont was very elemental in this process. And the EBMT have kept those guidelines going. The most recent broad guideline is from 2012. It's this document here. It's open access. It covers all the diseases. It's a useful reference point. And we've got some more recent guidelines coming out in systemic sclerosis and also in Crohn's disease. They're open access, and I'll touch on those a little bit later. So the registry, the EBMT registry for autoimmune diseases, this is the current state of play as of April 2018. We've got 2,653 transplant procedures in over 2,500 patients. Most patients are female, because that's how you'd expect autoimmune diseases to distribute. They're from a lot of different countries and a lot of centres, so we're all very grateful to them. The vast majority of patients are being treated with an autologous transplant, and there's a small minority of patients that are treated with allografts, and as you can see from the age of the allografts, the vast majority of those are in the paediatric setting. So today I'm going to just focus on the autologous transplant, because that's the one where most evidence is available, and that's the one where it's going to have a potential application in several autoimmune diseases, and it's also the most safely delivered type of transplant. Okay, so these are the indications. Multiple sclerosis is at the top of the table. Can you see my pointer? Yeah, so I'll use the pointer for various things. Multiple sclerosis, you've got connective tissue diseases, particularly scleroderma. You've got various forms of arthritis, but they're no longer treated commonly with transplant. Inflammatory bowel disease, mainly Crohn's disease, and then there's a whole range of other diseases. And I'll try and touch on most of those in the next 20 minutes or so. So this is the growth of autoimmune diseases being transplanted over the years. As you can see, there was an initial wave of interest in the early days, and then what happened was the biological revolution hit us in the 2000s. That was a good thing for many diseases, but it meant that we were competing with modern biological therapies and also the big pharma. So it didn't really develop as quickly as we thought it might do. But as time's gone on, there are diseases where, and there are patients where the biologicals are not a miracle treatment, and the transplant has found its niche in certain types of patients. So, and I'll go on to qualify the diseases a bit more. As you can see, this breaks down the different types of autoimmune disease by year. The blue is the MS. So you can see MS has always been a major indication over the years, and it's the one that's growing the most. As you can see, arthritis back in the late 1990s, when I started in the field, was quite a big indication as well. In fact, the main indication in 1999, but you had these biological therapies that really swept the floor in rheumatoid and other types of arthritis. The green is the scleroderma, and the red is the Crohn's. So you're really talking about the three main indications being MS, scleroderma, and Crohn's. So this is what this talk will focus on, and then I'll talk about the neurological indications, particularly MS, in the next 10 minutes or so. So multiple sclerosis, it's a growing indication, and this graph just illustrates that. The countries that have taken the lead in this, Italy. Italy is always very forward-thinking. Neurologists came on board very soon, early on, and it's always led the way. But Sweden has been a country that's caught up in MS. It's a small country, but the neurologists on board, there's a very high incidence of MS based on its geographical location. And we've got the UK, Poland, Spain, and so on. So it's depending very much on the neurological communities referring in patients, so by a country basis. So what is MS? MS is a biphasic disease. It starts usually in young people as a relapsing remitting disease, which is characterized by bouts of neuroinflammation that appear and go away, and gradually disability can be accumulated. But it's really in this phase that there's something to switch off. Later on, the secondary progressive phase, this is where you see people in wheelchairs, on sticks, and so on. It's a neurodegenerative phase of the disease. It's set in train. There's often no inflammation, but it's got a momentum of its own. Once you've got to that stage, you've really got little means of reversing it. So it's important to treat MS in the relapsing remitting phase. This is just a brief diagram to show how disability is measured by the EDSS scale, which runs from 0, normal, to 10, the patient has died, and around about 4 to 6, the patient sliding into that wheelchair, sliding onto sticks, losing their ambulation. So I'm just showing those just because it's important to refer to that a bit later on. Of course, MRI is an important assessment tool in MS and will show inflammation where there is gadolinium enhancement. And the ultimate treatment goal in MS is something called NIDA, no evidence of disease activity, which is no relapses, no MRI activity, no disability progression. So with any treatment, you're aiming for that goal in MS. And there are lots of treatments for MS. There are lots of biological treatments for MS. You'll be familiar with some of them. Some of them are old. Some of them are very much state-of-the-art and monoclonal antibody type treatments, including alemtuzumab. So we're competing with those. So this is just a historical slide to show you that the first transplants were done for MS in 1995, both in Thessaloniki with Anastasios Vassos, and also by Richard Burton in Chicago. So this is a new type of treatment, but what is new is the increasing evidence base. Now, in those early studies, it became very apparent that the major effect of MS was on the inflammatory lesions in the central nervous system. So we knew we could switch things off, but patients were, on the whole, still treated in a relatively advanced stage. And this is an EBMT trial called ASTIMS. It was led by Riccardo Siccardi and Gianluigi Mancardi. And it was a trial that sadly didn't really recruit as much as it wanted to. Only 21 patients, and it was comparing mitoxantrone with autologous stem cell transplantation using a Beam 18G regimen. But it did show that you could significantly reduce the MRI lesions and reduce the relapse rate. But it wasn't powerful enough, and the sort of patients that were being treated in a relatively advanced stage wasn't able to show a reduction in disability. But there was no TRM, and it kind of paved the way for other studies. And these other studies, have actually really brought forward the application to an earlier of HSCT to an earlier phase, because what's important is that we treat MS at this early relapsing remitting stage where you're switching off inflammation, not doing it after the disease has reached its neurodegenerative phase. You need to get in there early. So, and this was something that Richard Burt published on quite early on. He however hard you treat those advanced patients, even with total body irradiation-based regimens, it does not really make much difference. No inflammation, no response. So that's a good kind of baseline. So, and this was another study which looked at long-term outcomes. It's from Paolo Marraro. It looked at long-term outcomes in those earlier cohorts of patients, and it really identified that patients in the earlier forms of disease with relapsing, remitting MS do much better than the patients with secondary progressive or primary progressive MS. So you shouldn't be treating those patients with secondary progressive and primary progressive MS. You need to get patients early when there's some inflammation to switch off. And so this is another EBMT slide which shows that you can that shows the trend. In the early days, almost all patients were treated for advanced progressive MS. Nowadays, very few patients are treated for advanced progressive MS, and it's getting the right balance. Centres are treating relapsing remitting MS. So that's so. So okay, so there's an increasing evidence base in relapsing remitting MS. This is Richard Burt's paper from a few years ago. It treated a large number of patients and showed a reduction in that EDSS level from 4 to 3, so moderate disability to mild disability. That was with cyclophosphamide and ATG, a non-myeloablative autograft. Look at these figures: 80% 4-year relapse-free survival, treatment-related mortality 0. So this is what the neurologists want to see. They want to see it's safe and it's highly efficacious, and that's about 3/4 of patients are going for disease stability in the medium long term. This is a reduction in the EDSS scores in that paper. Again, it shows it going from moderate to milder disability. That's almost unheard of with many MS treatments to improve disability. Mostly it's about stabilization. Now, then came along the Swedes with their retrospective experience. It was using Beam ATG predominantly, and they were able to replicate this 80%-ish relapse-free survival at 5 years. And again, they got the confidence of the neurologist by having a TRM of 0. This is vital that the TRM is kept well below 1%, because neurologists aren't used to dealing with this level of the toxicities that we deal with in our cancer transplant patients. Again, this is Richard Nash and the Seattle, Colorado group. They had a smaller cohort in the States, but you've got 25 patients. There's no TRM. You've got that similar level of disease-free survival, at about 3/4 of patients over 5 years, 62 months. So you're getting those results that are quite consistent in the right types of patients. Again, this is Richard Nash's EDSS going from moderate disability down to milder disability. It's showing an improvement. So this is Richard Burt's MIST trial. He's led it. We've taken part in it. We're the UK contingent in the MIST trial, and it's also been Sweden and Brazil, and it was presented at the opening ceremony. It got the Van Beckham prize for the best clinical abstract in the EBMT. And I can't go into too much detail, but I can relay what is in the abstract. So these were patients on stable disease-modifying treatment, and despite that, we're getting more than 2 relapses in the previous 12 months. And they were randomized to either transplant with cyclophosphamide ATG versus disease-modifying treatments. And so 10 patients were randomized. There were a few withdrawals, no deaths, and patients were followed up for at least 12 months. During the first year, 1 relapse occurred in the transplant arm versus 39 in the disease-modifying treatment arm. The mean EDSS score, disability score, improved from 3.5, to 2.4 with transplant, whereas it worsened in the disease-modifying treatments. And then 60% after 3 years in the control arm had failed treatment. they progressed with a disability, whereas only 6% had progressed with the autologous transplant. So HSCT is statistically superior to ongoing DMTs. And I should add that the DMTs in this study, because of a historical factor, did not include alemtuzumab, and that's probably the one remaining question. It included lots of modern disease-modifying treatments such as natalizumab, fingolimod, dimethyl fumarate, but it didn't include alemtuzumab. So that's a little weakness of the study, but it does prove the principle that you can get very good responses with what is a relatively straightforward conditioning regimen, cyclophosphamide 200 milligrams plus rabbit ATG. So, as hematologists, should we treat harder or softer? You know, it's always nice to get better results, or even have a softer regimen that is less toxicity. So, this is what Riccardo Siccardi did. He tried to reduce the intensity of the conditioning down to cyclophosphamide 120 plus ATG. But unfortunately, he found that the patients relapsed more compared with his standard Beam ATG regimen. So you probably can't go much softer than what Richard Burt is doing. Can you go harder? Of course you can go harder. We can always go harder as hematologists. We sometimes like to ramp up things, but and this is a study that was published in the Lancet by Harry Atkins and the Ottawa group. Very good study, 24 patients, and they pushed the patients hard. They gave them 4.5 grams per meter squared of cyclophosphamide just for mobilization, and then they gave them Bucy, ATG, and a CD34 selected autologous transplant. Yeah, so that's about as hard as you can go without using total body radiation. Now, I think that they probably got better responses. In fact, they got the rate of brain atrophy decreased to that of normal individual controls. So I think that they got good results in terms of the MS, but the big but is that 2 patients developed veno-occlusive disease and 1 patient died of that. Now, that's probably not a very good basis for selling this to the neurological community. You don't want any excess toxicity. So I personally think this is a good paper, but I don't think we should go much harder than the 2 EBMT recommended regimens, which are cyclophosphamide 200 milligrams per kilogram plus ATG. That's a generic autoimmune disease regimen. And there's also one for MS. It's Riccardo Siccardi's Beam plus ATG. So those are the 2 regimens that are used mainly across Europe. We don't know which one is better, but we are doing a retrospective study on those 2 studies to see if we can come out with any recommendation. And then this is just a snapshot. As you can see, the blue is the cyclophosphamide ATG, and the yellow-orange is the Beam ATG, which was the one traditionally used for many years. But you can see that most patients in Europe have been treated by with the cyclophosphamide ATG. So we're going to look at those 2. You might want to go a little bit harder with Beam ATG, or you might want to go a little bit softer with cyclophosphamide ATG. What's important is a sort of balance of risks and benefits. So future RCTs in MS, there's still this question of HSCT versus the best highly active disease-modifying agent. Now, this is a complex graph, but it's a little bit hard for hematologists to understand, I think. But basically, these upper curves are the NIDA, the no evidence of disease activity. With transplantation, you've got figures of 80%, 90% NIDA. That's pretty good. These lower curves down here are the very large MS trials. This is what you get with alemtuzumab and other MS trials. NIDA. As you can see, the NIDA rate is about 50%, and at best, it really is only about 50% with new drugs such as alemtuzumab and ocrelizumab. However, the neurologists are used to their own drugs, and they know how to administer them, and so we are up against proving that transplant can at least match or better these modern approaches. So in order to define the place for transplant in the therapeutic strategies for relapsing remitting MS, we need to do a clinical trial, a randomized control against these newer agents, ocrelizumab, alemtuzumab. I think that the latter is much more widely used. So a number of places around the world are planning, I think it's ongoing at the moment, not too far from yourselves in Lithuania, in the Nordic countries. There's a trial going on between Norway, Sweden, Denmark, and I think Finland. I don't know whether it will be open to any other countries in your region, comparing transplant with alemtuzumab. There's likely to be one in the UK. So that's what we need to do: put patients on trials. So I'll move on from the MS to just mention the other neurological diseases that are treated, and these are really small numbers. It's diseases like neuromyelitis optica, chronic inflammatory demyelinating polyneuropathy, myasthenia gravis, stiff person syndrome. When you start working with your neurologists, they might give you some of these patients to consider for transplant, but there's never going to be any large clinical trial in those diseases. They're rare. There's varying levels of evidence. You have to look at the case series and case reports. So I'll go on to rheumatology now, just to touch particularly on connective tissue diseases. As I've mentioned, the main indication is scleroderma. That's the blue in this graph from the EMT registry. So systemic sclerosis, or scleroderma, it's a nasty disease. It's a bit like some of our chronic lymphomas. It's got a mortality rate, particularly in some severely affected patients. There's a substantial mortality rate from the disease, which is unusual for rheumatological diseases. It usually causes disability, but this causes both disability and shortened life expectancy. And there really isn't many good treatments for systemic sclerosis. There's cyclophosphamide, mycophenolate, and then there's supportive care. And there are evolving treatments, but I don't think they're really coming up to much. So autologous stem cell transplantation has found a niche. This is just a quick slide to show you that this study that compared mycophenolate with cyclophosphamide really did only show very modest improvement in either arm, and really there isn't a good treatment for severe systemic sclerosis. So transplantation has become quite accepted in the rheumatological community for these severely affected patients. It's a rare disease, so there aren't so many done, but it's on the increase. And they're mainly done in Germany, Netherlands, France, Italy. It's variable, the uptake, but there are some countries that have embraced this, particularly Germany, Netherlands, and France. The sort of changes you can see almost immediately in scleroderma is the reduction in the skin score. And that is something you'll see if you ever transplant these patients. You'll see it happening sometimes with mobilization, but particularly during the transplant phase. The skin gets softer, the Rodnan score goes down, and ultimately there's regression of skin fibrosis and revascularization of the skin. So this is another Richard Burt study. It's small. It only included about 21 patients, I think, in each arm, but it was finished early because the results were so remarkable that there was improvement in skin score. I should say the comparator was called cyclophosphamide, and with transplant there were better outcomes with skin score, but more significantly with lung function and quality of life. And these are some graphs that show you improvement in Rodnan skin score, and the second graph shows improvement in transfer factors. And Richard Burton and his colleagues did some very elaborate modelling of lung function to measure total volume of diseased lung, and was able to show improvements in the transplant arm in that respect. So that's important because it's the organ damage that kills the patient, not the skin. So what about survival? Now this was this very long-running EBMT-ASTIS trial. It ran for a long time, and yes, it did confirm that you have improved survival in severely affected diffuse cutaneous systemic sclerosis with the transplant versus the control group, which got, again, pulsed cyclophosphamide. It showed improved event-free survival and overall survival. So that was a good outcome, but the treatment has not been taken up as much as many would have hoped in the rheumatological community, because that trial, which was done over quite a number of years, over a decade of recruitment, had a treatment-related mortality of 10%. That's too high, really, for many rheumatologists to take on board. So, but it did prove the principle that the outcomes were better with the transplant in the longer term. And this is another trial which really replicates the same results using a different conditioning regimen. This is Keith Sullivan's trial that was published in the New England Journal of Medicine, which shows very similar curves. He used a conditioning regimen which included total body irradiation, it included cyclophosphamide and CD34 selection. So again, you can show that there's an improvement. There was an early treatment-related mortality of 3%, and then there was a later total treatment-related mortality of 6%. So you still haven't eliminated the risks, but with advances in supportive care and patient selection, there is an improvement in the safety of delivering the procedure. This is a good editorial by Dominique Farge and Richard Burt, looking at all 4 trials. I'm not going to go into great detail with it, but it's a summary that you could access if you want to read more about this. Now, the big thing about transplanting in scleroderma is doing it safely, in my opinion anyway. You don't want to have the treatment-related mortality that scares the rheumatologists off. Obviously, you don't want it to for the patient as well. And the best way of delivering this safely, of course, you want to deliver it in a very experienced unit. That's important, but you want to screen these patients for cardiopulmonary fitness. We've produced these guidelines in 2017. They're open access. It tells you how to screen patients for transplant, and it involves cardiac catheters, cardiac MRI, looking carefully for pulmonary hypertension. There's all sorts of issues that you need to address. You need to work closely with cardiologists or pulmonary hypertension pulmonologists, and it will tell you how to select the patients for transplant and select out those that aren't going to do well. So it's vitally important that this is done. And in that way, in my unit, I mean, we've not transplanted as many as other units, but we've never lost a patient with systemic sclerosis because we've been very selective, and we've chosen those patients who have got the adequate cardiopulmonary fitness. Now, just to illustrate that this treatment is being accepted by the
John, can you hear me? Sorry,
accepted by the rheumatologist.
We're running very late. I know it's not your fault.
Running a bit.
Can I ask you just to not stop, but just 5 minutes more? Can you manage it in 5 minutes?
Okay, I'll whip through this. This is just to mention that the European League Against Rheumatism have now put recommendations for transplant within their guidelines. So I'm going to whip through these other rheumatic diseases because they are historical, largely because other treatments have come on board for lupus and rheumatoid arthritis and juvenile idiopathic arthritis and vasculitis. These aren't common indications for transplant anymore, although patients are occasionally registered in the EBMT database. So that's a sort of historical mention that they've been treated with transplant, but because of good biological therapy, modern therapy, they're not really common candidates. So I'll just go on to Crohn's to wrap up. You'll be familiar with Crohn's disease. It affects young people. It's disabling, and it's a disease for which there's been a lot of biological therapies, but there still are patients that are dependent on steroids, are dependent on surgery, and in whom the biologicals don't work. So there is an interest in using HSCT in Crohn's disease. It's not as well established as the other indications that I've talked about. It's being used predominantly in Spain and the United Kingdom and Italy. This was the EBMT ASTIC trial. You can produce profound responses with a transplant, and the control arm again had best supportive care, and were able to have a delayed transplant again, produce profound responses. Although the ASTIC trial was a negative trial because of its over-ambitious endpoint, sadly. But it did show that around about half of patients could have very profound responses. This is real-world data. This is a retrospective study from the EBMT. And we looked at 82 patients who'd been very heavily pre-treated. You can see that a lot of them had major surgery and lots of lines of treatment. And so heavily pre-treated patients. These are the responses at 100 days, 1 year, and last follow-up. And you can see in around about half the patients, they remain in remission, or they've improved otherwise. So you can get these good responses in Crohn's disease, but the caveat is that around 3/4 of patients receive medical therapy and some require surgery. However, around about half continue in a long-term remission if they are maintained or salvaged with the reintroduction of treatments that they have previously lost response to or been non-responsive. So you're managing to transform the disease into something that's manageable. And so transplant in Crohn's disease looks like it's going to have a role, but it's not as easy to define because it is dependent on patients being treated with the reintroduction of some previous agents, but resets the disease in a more manageable form. And we've just produced these recommendations with the European Crohn's and Colitis Organization, and they're open access. They're in the Journal of Crohn's and Colitis. You can read more about how you can select and treat patients with transplant. And ideally, patients should be on a clinical trial. We've got a clinical trial that's just starting up in the UK, comparing transplant to best standard of care. So I'm in the last few minutes of my talk. Other diseases that have been treated: hematological cytopenias, insulin-dependent diabetes, which is an interesting state to treat. It's been mainly treated in China, in Poland, and in Brazil. About over 100 patients have been treated. About half of them, if you treat them in the honeymoon phase of their disease, they are able to reduce or even come off their insulin. It's proving a principle that if you can switch off an immune process early enough, then you can alter the course of the disease. But it's not been widely adopted in the diabetology community. And I'll just round off with talking about how does this treatment work. Certainly you get a debulking of inflammation with any cytotoxic treatment, if you give cyclophosphamide or beam or TBI, you get a debulking of inflammation. So that gives the patient an immediate benefit throughout the transplant. But what you want is the long-term response, and that comes from an immune reboot or a resetting of immunity that you get from autologous stem cell transplantation. So it does appear that in some diseases, at least, you go from this very skewed T-cell repertoire, this is in the regulatory T-cell population, back to these normal kaleidoscopic diversified types of T-cell repertoire. And that's what you're wanting to achieve. You're wanting to get away from the skewed to the re-diversification of the immune repertoire. And that appears to be associated with clinical responses. And it might be that through thymic re-education or other pathways, you're able to reset the autoimmune disease, reboot the immune system. And further work needs to be done in different diseases. But work it has established that kind of change occurring with autologous transplant. So I'll conclude by saying that autologous transplant is capable of major clinical responses in otherwise resistant patients, providing they have inflammatory activity. The future depends on the dynamic with alternative treatment options, including the newer disease-modifying treatments, biological therapies, and so on. And future studies need to establish the best transplant regimen for each disease, the relative benefit over current and future disease-modifying biological treatments, and to define the mechanisms and develop clinical biomarkers. This is just some acknowledgements to some of the people that work with me, Professor Basil Sharak and Professor Paolo Marraro, a couple of the neurologists. So it's been a real cross-fertilization of specialties, and by destroying and then selectively rebuilding the hematopoietic and immune systems, it might not only produce good clinical benefits for patients, but important insights into the pathogenesis of autoimmune diseases. A couple of slides for the Autoimmune Diseases Working Party, and then just to finish off, you're all welcome to come to Florence this November for the joint educational meeting of the Autoimmune Diseases Working Party and Severe Aplastic Anemia Working Party. Thank you very much.
Thank you, John.